Another change that is going to have a big impact in 2015 is the individual mandate, and this kind of goes hand in hand with changes to the transitional reinsurance program in the individual market. This is the transitional reinsurance program, most of you probably know, but plans in the small group and individual and large group, as well as the self-insured markets, all contribute a per capita contribution, and then this is used in the individual market to provide reimbursement to plans that have plans for coverage for people with higher than expected health care costs. In 2014, those payments total $10 billion, so it's a pretty significant portion of the individual market premium and serves to keep premiums low, but that phases out over time. So next year in 2015, it goes down to $6 billion, and then in 2014, again down to $4 billion before it's completely phased out in 2017. And this coincides with the phasing in of the individual mandate penalties, pushing more and more people into the individual market. So hopefully these two will balance each other out in keeping premiums down in the individual market. But again, this is going to be something that we're going to have to keep our eye on and see how it goes. This will become apparent in all the rate filings for the next several years going forward. Speaking of the individual mandate, another thing that you'll probably see right around April 15th of next year, between the beginning of the year and April 15th, is going to be centered around the income tax filings and what happens to individuals whose income was incorrectly stated on their applications for subsidies in the exchange. There's just a piece in the Washington Post late last week that there are about 1 million Americans who, when they applied for coverage on the exchange, the income that they provided on their application didn't match up with the federal data sources that they were trying to verify that against. And when that happened, those individuals were asked to submit supporting documentation, either by mail or by uploading a copy of it. And they did that and were put in coverage based on their reported income. The problem is that the system to match that supporting documentation up with those applications hasn't been built yet. And so we don't know. Some of these people may have subsidies that are too high. Some of them may have subsidies that are too low. You know, for those who had subsidies that are too low, they may get a pleasant surprise in April of 2015. But for those who had subsidies that are too high, it's going to be really unpleasant surprise when they go through their tax filing process, and at the end of the day, they owe a sizable check to the federal government to make up for those premiums that they got but shouldn't have gotten. And I guarantee you policymakers in Washington are going to hear about this. We're going to hear a lot about this in the news and from Congress as this starts to approach. You know, not coincidentally, that's just as the new Congress is starting its work, and we have this short window of time when you can actually get something done before the presidential campaign really begins in earnest later that year. So speaking of the elections, we've got court cases and elections coming up. As far as the litigation side of things is concerned, you've got two major cases that are working their way through the system right now. The first one has to do with the origination clause in the Constitution. And that states that any legislation that raises taxes or spends money must originate in the House of Representatives and not the Senate. As you remember, this was a Senate bill that passed. It was written largely in the Senate. But the way they did this was by taking an unrelated piece of legislation from the House of Representatives that had been reported by the Ways and Means Committee and sent over to the Senate after passage in the House, that dealt with making the home buying process more affordable for former service members. They took everything out of that legislation and dropped in the Affordable Care Act. Now, this is something that's been used for years and years and years and years and years on Capitol Hill as a way for the Senate to get around that origination clause. And the Affordable Care Act is now being challenged on the grounds that the substance of the legislation did not originate in the House of Representatives. And it'll be interesting to see what happens with this. I would be very surprised as a constitutional scholar who did not go to law school if the law is overturned on those grounds, but it'll be an interesting case nonetheless. The other case that's going through the process now has to do with whether or not subsidies can be provided in federally facilitated exchange states. The provision that provides the subsidies does say that people are eligible for subsidies if they have coverage through a state-based exchange, but the rest of the statute leads one to believe that those subsidies were available in federally facilitated exchange states as well. And I'm going to say, having gone through the process of working with Congress when they were developing this, no one on Capitol Hill thought that this was limited to the federally facilitated exchange, to the state-based exchange states. Everyone was operating under the assumption that these would be available in federally facilitated exchange states too. This was reflected in Congressional Budget Office scores that were put out before the law passed. But this is another interesting case to watch. If those subsidies in federally facilitated exchange states are struck down, that's going to create a huge problem for the 34 states that are federally facilitated exchange states. Then elections. We've got elections later this year. Control of the Senate is up for grabs. It looks like Republicans may have an edge there to take over the Senate. If they do, how much of an advantage will they have in the Senate? As you probably know, it takes 60 votes in the Senate to get anything done these days, except for nominations. So it's a question as to what the Senate will be able to get done in 2015, or if control stays the same, what they'll be able to get done. I think there's some movement towards there being more of an appetite for some of the targeted fixes that any major piece of legislation like the Affordable Care Act needs, and I'll get to some of those in a little bit. But we'll see. I think the politics around this have been unpredictable, to say the least, and that'll be yet another thing to keep our eye on going forward. So 2016 and beyond, what do we see after 2015? The biggest thing right now is that there are a whole series of regulations that expire, and the biggest of these is the essential health benefits regulation, which covers what has to be covered in an insurance policy in the individual and small group market. The regulations that HHS put out are only good through the end of 2015. So we don't know what's going to be required in these plans. We don't know whether states will have a role in deciding what's going to be required in plans in 2016 and beyond. We certainly would hope that they do. I think that's has been a good way to do it. But we need to know very soon what that looks like, even though we're still in the 2015 plan management cycle, and at the beginning of it, the carriers need to know what's going to be included in those plans. They have to price those plans. They have to put them together. The states are going to have to make a decision if they have a role as to what that's going to be in 2016. And you've got a lot of states with biennial legislatures, which means who are meeting now. And so we really need this information in short order as to what those plans are going to look like in 2016. And we are screaming this at anyone who will listen in Washington, that we need this information. Hopefully they will come out with it soon, and it'll look pretty much like what we have now, but we don't know. In 2017, those reinsurance and risk corridor programs will completely phase out, leaving the individual market to stand on its own. And you have the transitional plans also phasing out. So that's going to be a big theme going forward as to, how many of these people in the transitional plans get integrated into the single risk pool. When does that happen? Does it happen just when those plans expire in 2017, or will carriers start moving them into those plans earlier by declining not to go all the way to 2016 with those renewals? Who's going to operate the exchanges? As it was mentioned earlier, the states had kind of a varied result with their health insurance exchanges. Some of them did very well, some of them not so much. And some of those states that had a lot of problems are moving, at least for the time being, to the federally facilitated exchange model, having the federal government take over the operation of those exchanges, at least from the IT side. There may be some states that are looking at moving into a state-based exchange. You had some states that had provisional approval to run a state-based exchange that weren't able to get the IT work done by open enrollment. They have the federal government operating the IT side of things. They're moving to fully fledged state-based exchange status next year. Are there going to be other states that follow suit? If there are, it's going to be a lot more expensive because the grants, in order to put those systems together, are no longer available. But will the federal government help the states out by saying, hey, you can be a state-based exchange, but just like New Mexico did and Idaho did in 2014, you can use our systems. We'll just be the contractor, and you can take over the policy side of things to a greater extent than you already do. That's something that we're going to begin pushing the federal government to consider, to give states more flexibility without the burden of developing these systems on their own with no grant support. You've got state innovation waivers that can kick in 2017. This is a plan that allows states to try and reach the same goals as the Affordable Care Act in terms of number of people coverage and affordability of the coverage, comprehensiveness of the coverage, but doing it their own way. Vermont has a system underway to transition to a single payer program. Hawaii has a more targeted one looking at their shop exchange because there are very few small businesses in Hawaii that don't provide coverage to their employees because of an employer mandate that's been on the books for about 30 years there now. And some states may look at some more targeted things as well. A big issue is the small group market. In 2016, that will change. Currently, most states define the small group market as employers that have between 2 and 50 employees. Well, that goes to 1 to 100 in 2016. And that means you're going to have a lot of those larger small businesses now being pulled together with the micro businesses. What's that going to do to premiums? What's that going to do to incidents of self-insurance among these small businesses who are doing it to some extent now, but will this increase that, and what will that do to premiums in the market? If you've got healthier small businesses self-insuring with a stop-loss policy to back that up, and these 50 to 100 businesses are the ones who are going to be most likely to be able to do that, that could have an impact on premiums. That's something that the NAIC is looking at very closely. We're just finishing up a white paper on this subject. And how states deal with that is going to depend on the experience that we see. There's going to be additional requirements on insurers to post quality information, as well as to conduct surveys of their enrollees and their satisfaction. And all that information will be reflected on the health insurance exchanges beginning in 2016. And that's going to be an additional administrative burden that the carriers are going to have to comply with. But it'll also hopefully provide some good information to consumers shopping for plans and getting a good sense of what they can expect when they're enrolled. Then another area is the administrative costs. There's a number of duplicative requirements right now. For instance, filings have to be filed both with the state, as they always have been, in many cases through the NAIC's SURF system. But then the insurers have to turn around and make those filings with the federal government as well, separately. Is that really necessary? Can't we find a way for the federal government to access those existing state filings through those existing systems that insurers are used to working with. They already have the infrastructure in place to work with the NAIC SURF system. This is an area where we can save some money and keep premiums from growing a little bit more. And then finally, costs. We have to address the underlying healthcare costs, and that's going to be key. You can have all the reforms you want around access to coverage. If those underlying costs continue to increase, you're going to see those problems reappear when people can't afford it. Then finally, there's a handful of other issues that are hanging out there, some of which have been addressed preliminarily in regulations that we just got tail end of last week, a big 400-page stack of regs that states are going through and trying to figure out exactly what's in them, as are the carriers. One of the highest profile of these had to do with fixed indemnity plans. Previously, the federal regulations said that these had to be sold on a per period of time, or they had to reimburse on a per period of time basis. So for a day of hospitalization, it would pay X amount per day. A lot of carriers wanted to reimburse on a per service basis as well. So a certain amount for a day of hospitalization, a certain amount for an office visit, a certain amount for lab services. That would vary. HHS came out with regulations just this past week that basically said you can reimburse on the per service basis, but it has to be sold only to individuals who also have minimum essential coverage that meets the individual mandate. So it can only be sold as a supplemental product. So something that the states, there are a lot of questions regarding how exactly that works. What if someone says they have minimum essential coverage, turns out they don't? If that's no longer accepted benefits, what does that do to all the other individuals who are enrolled in that plan? There are a lot of ramifications that hadn't been thought through real clearly. I think the regs are going to start to give some clarity, or not everything I think that we wanted, but the insurer is just going to have to collect an attestation from each individual purchasing that plan that they do indeed have other coverage that provides the essential health benefits. And then it's being phased in. This doesn't take effect until January 1st of next year. So we have some time, a little bit of time, to get ready to put that into place. The risk corridors, also in those regulations, there was a change. In the way the law was written, if a carrier has health costs that exceed a certain threshold, they'll receive a portion of that back from the risk corridor program. If their medical costs are below 3% or below 97% of what they were expecting, then they have to pay into that risk corridor program. But the way it's written, those two don't necessarily balance out. If your costs are below that threshold, you pay. If they're above that threshold, the program pays. But with the changes to the transitional relief program that the administration put into place, that may change the calculus somewhat. Originally, CBO had expected that this would net the federal government $8.5 billion. That is, carriers would, on average, have lower than expected health care costs, and so they'd all be, more would be paying in than taking out. With the changes under the transitional relief program, if that increased the average cost in the for the plans that are eligible for this program, and if it increases it for an increasing number of those plans, those costs may not balance out. And there is some question as to whether or not HHS could access those additional funds beyond what's collected by the program without an appropriation from Congress. So what they said was, we're going to operate this in a budget neutral manner, which makes a lot of people nervous. It sounds good on its face, but this is a mid-year change. Plans had already been filed. The rates can't be changed for 2014, and this may impact what the carriers see coming in the door in terms of money. We're going to have to wait to see until about the middle of next year exactly how this plays out, but it's something that we're watching very closely. In these regulations, they said, if the costs do exceed what comes in, It will be budget neutral, but they'll find other sources of revenue to make up that difference, which I hope is right. But again, we shall see. There are a number of states that would like more flexibility around their open enrollment periods. What HHS so far has said is that you have to have the federal open enrollment period and only the federal open enrollment period. There's no flexibility there. I'm not sure that this is a valid reading of the law, but that's what they're going with. There are a number of states that would like broader open enrollment periods. I think we'd accept that a state can't restrict their open enrollment period to less than the federal enrollment period, but some states would like to extend beyond, either before or after that federal enrollment period. And so far the answer has been no from HHS. It's something that we continue to work on with them. The product changes, what are we going to see in reaction to changes from from the carriers based on what they're seeing on the ground, and what's the reaction going to be from regulators and consumers to those product changes. And finally, there's some issues in the territories. There's no individual mandate in the territories. There are no subsidies in the territories. There are market reforms in the territories. So this drives up costs without any of the things that help to contain them. And then, as was alluded to earlier, we have the new regulations coming out on navigators that were in that 400-page packet that came out on Friday. That's something that states are still digesting. You're going to have a panel on the navigator issue later today. But there's also been some litigation. State of Missouri had their navigator program struck down by a court, basically saying that unless you operate your own exchange, you have no authority over navigators whatsoever. You can't license them, you can't certify them, you can't put any additional requirements on them. In their regulation, HHS didn't quite take that tack. They're still allowing states to have some oversight, but there are some bounds around what kind of restrictions states can put on navigators. So with that, I went on longer than I planned to, but I think we still have a few minutes for some questions, which I'd love to be able to answer.